Parasitic infections of the eye are an exceedingly uncommon presentation, more often prevalent in tropical regions. Both protozoan and metazoan infections have been described. Metazoa are further classified into nematodes, cestodes, and trematodes. Ocular presentation may be the first manifestation of systemic disease and requires prompt, appropriate systemic investigation. In addition to antihelminthic medication, it is prudent to remove the parasite surgically from an easily accessible site of infestation. Care is taken to remove the worm in toto so that inadvertent release of toxins can be avoided. We present 2 cases of ocular nematodal infestation and their surgical removal. In the first case, a 37-year-old man, agriculturalist by profession, presented to us with complaints of intermittently seeing a wiper in front of his left eye for the past 3 months. He was already on tablet diethylcarbamazine 500 mg for the past 15 days. There was no history of swelling or redness over any other part of the body, suggestive of calabar swellings. On ocular examination, there was a mild conjunctival congestion. A live, mobile, semi-transparent worm was seen moving in the anterior chamber. The patient's unusual symptoms could therefore be explained by the movement of the worm across the pupil. There was corneal edema in the infero-nasal part with a few cells in anterior chamber. The rest of the ocular examination was normal. The patient was taken up for surgical excision of the worm under peribulbar anesthesia. Anesthesia made the worm less motile. The anterior chamber was accessed via a limbal incision, an entry made with a 3.2 mm keratome. The anterior chamber was filled with hyaluronic acid to form the anterior chamber as well as immobilize the worm. The worm was initially hooked with a Sinskey hook to pull it towards the incision site, taking care not to disturb any other intraocular structures. As the worm approached the incision site, pressure was placed on the posterior lip of the incision to allow for a slow and careful visco-expression of the worm out of the anterior chamber in toto. An anterior chamber wash was done with ringer lactate and the incision site sutured with 10-0 nylon sutures. Macroscopic and microscopic examination revealed a thin, off-white, semi-transparent, cylindrical structure measuring 2 mm long. The body had a cuticle, while the anterior end had a mouth and posterior end was rounded, characteristic of a male loa loa. Systemic workup revealed normal routine blood investigations. Blood smears for microfilaria were negative. Tablet diethylcarbamazine 500 mg was continued for 3 weeks. Topical gatifloxacin eye drops 4 times per day were instilled for 1 week, as well as prednisolone acetate 1% eye drops 8 times per day for 1 week, tapered weekly. On last follow-up at 3 months, the eye was quiet and the patient doing well. The second case is that of a 67-year-old lady with complaints of something moving in her left eye for the past 1 month. On close inspection, a mobile, curvilinear, semi-transparent worm was seen lying in the superiotemporal bulbar subconjunctival area. Apart from diffuse conjunctival congestion, the rest of the ocular examination was unremarkable and visual acuity was 20 by 25. The patient was scheduled for a surgical excision of the worm. By evening, the worm had migrated to the inferonasal bulbar subconjunctival area. Prompt removal is mandatory as the worm can quickly migrate into the orbit and other periocular tissues. A peritomy from 3 to 5 o'clock adjacent to the worm was made. The conjunctiva was retracted to reveal the worm. It was found entangled in the subconjunctival tissue and Tenon's membrane. The worm was carefully removed in toto from the subconjunctival site by gradually pulling it out from one end. It may also be removed with atraumatic forceps. In case of any movement of the worm, it may have to be grasped through the conjunctiva to immobilize it and prevent its rapid migration. Injection of lignocaine anesthetic subconjunctivally around the worm has also been described to paralyze and immobilize it. Although it is described that the outer cuticle of the worm imparts firmness to the body, care was taken to avoid excessive traction that may cause injury to the structure of the worm. This would result in release of toxins and subsequent inflammation in the surrounding tissue. The conjunctiva was resutured with 80 vicryl interrupted sutures. Gross examination showed a long, tubular, white-colored smooth worm measuring around 13 to 15 centimeters in length and about 2 millimeters in diameter. The worm was tapering at both ends. The worm's posterior end was curved ventrally with a bluntly pointed tail. These gross features were diagnostic of roundworm or Ascaris lumbricoides, which belong to the phylum Nematoda. Microscopic examination showed an outer non-nucleated cuticle. The cuticle had circular striations, thin hypodermis, and a muscular layer. There was presence of only longitudinal muscle layer with absence of circular muscle layer. The worm had 3 lips, and these can be appreciated in a tangential section through the anterior end of the worm.